So moving on to an interesting session, we move on to the AM NAGAPPA oration. For this, I would like to call upon the chairpersons, Dr. Chandra V, who's the consultant physician and diabetologist, Professor of Medicine, SIMS and RI, Bengaluru. And I would also like to call upon Dr. NAGAPPA, who's the Vice Chancellor, GSS Academy of Higher Education and Research at Mysuru. We welcome you on stage, doctors.
Can we invite and make him sit here? Good afternoon to everybody. It's a great pleasure to chair this prestigious session of AM NAGAPPA oration, who was grandfather of Dr. Srinivas Murthy. Affectionately, he has commemorated his grandfather's name for this oration. And this oration is this time awarded to Dr. Sunil Gupta. I request Sunil Gupta ji to come and occupy the chair here. And congratulations to you,
I
sir.
think the clap can be a little louder.
Just take chair. Dear colleagues, I am happy to read this citation, which is going to be awarded to Dr. Sunil Gupta ji. Dr. Sunil Gupta is CEO and Managing Director of Sunil's Diabetes Care and Research Center, Private Limited, Nagpur. He holds several prestigious qualifications, including MD, FACE USA, FRCP London, Glasgow, Edinburgh, FACP, FICP, FIAMS, FIACM, FDI, and Fellow of Royal RSSDI, reflecting his vast expertise and commitment to excellence in diabetes care. He currently serves as the National President-elect for RSSD headquarters for 2026, and earlier served as the National President of Diabetes in Pregnancy Study Group and India, that is DIPSI, during 2021 and 22. Dr. Gupta's remarkable career includes 34 prestigious orations, 6 international fellowships, 7 national fellowships, 44 awards, and numerous recognitions from academic and social organizations. Among his notable achievements, he is the only diabetologist from India to receive the Outstanding Young Person of the World Award in 2002 in the United States. His name has been recorded in the Guinness Book of World Records, the Limca Book of Records, and the Asia Book of Records, reflecting a global recognition of his work. He has published 241 scientific articles, book chapters, abstracts, and has received 6 consecutive Best National Research Paper Awards from RSSDI. Over the past 3 decades, Dr. Gupta has conducted more than 3,400 academic and educational programs, contributing immensely to diabetes awareness and medical education across the country. Dr. Sunil Gupta's journey reflects dedication to science, patient care, research, and education. His work continues to inspire the medical community and improve the lives of people living with diabetes. With this, we have a great pleasure in awarding this oration to Dr. Sunil Gupta ji, and I request Srinivas Murthy to come on stage and get the oration plaque.
I would also request Dr. Jyotirmay, who's the immediate past president of API, to be on stage, please. Can we have a round of applause, please? A little more louder, as loud as possible.
Now I request my co-chair, Dr. V. Chandraya, to say a few words, and we will be requesting Sunil Gupta ji to go ahead with oration.
Now, we are going to hear from Dr. Sunil Gupta on a topic which is of great relevance because we see many pregnant ladies coming to the physicians for the management of diabetes. For 3 decades, he has served in the field of diabetology and he was heading the group of DIPSI group. So he is the right person to speak on diabetes in pregnancy, the clinical lessons and evolving Indian perspectives for last 3 decades, what has been changed, guidelines, management and other things. Now over to Dr. Gupta, please.
Good morning. Do we have the respected chairperson and our August gathering here? Thank you very much for this honor, for your good words and the wonderful citation. Thank you, LSM, for LSM. Yeah, thank you very much. Is busy talking to and getting things organized. So thank you very much, every one of you here for this, for your praise and good words. My today's talk, and it is an utmost big honor, I presume, that I'm delivering a talk on the name of a person who's a mentor to LSM, and he shared multiple stories of his Dadaji earlier, almost in half an hour talk we had on this topic, and I really feel honored. Thank you very much. This is more of a personal honor to me rather than just an academic and professional award. So thank you very much, ILET Academy and LSM. And before I forget, I invite you for the Hello Diabetes Academia in June 2026. And more than that is the forthcoming RSSDI 54. So both of us, including LSM as an organizing secretary, we have many other people here who are in the organizing committee. On behalf of every one of you and the headquarters, the RSSD official body of EC, we invite all of you to please block your date and we'll be meeting with full enthusiasm at this venue. No conflict of interest for this particular session. We'll have introduction, my inspirations, then we'll have some global and Indian perspective for hyperglycemic pregnancy, and we have some our own evidences which are rarely have been found, and we'll share why it is being unique. And then our thirst for awareness will be the last part of it. These are the people who have brought me here to this dais. Professor Sam G.P. Moses, who instigated me to go for the pregnancy diabetes as a sub-specialty. Dr. Asgaonkar from Mumbai for education. And then none other than Professor Sheshaya, who actually encouraged me even today for diabetes in pregnancy. And those days, almost 25 to 26 years from now, 1999, when Dr. Sheshaya came by train from Chennai to Nagpur to deliver an oration on pregnancy diabetes. And then we took, almost 17 years back, we took a national meeting of diabetes in DIPSI at Nagpur. And that was the first time that it has come out from Chennai to other destination. Nagpur was the second destination next to Chennai. Before that, it was only being got organized in Chennai. So these are those days we are active into it, and now these are recent 2025 and 26 when I'm working with Dr. Sheshaya and his blessings. And those days, Dr. Jitendra Singh was joint secretary of DIPSI, and I was the co-joint secretary of DIPSI. So we both were having the same position. And this was an absolute pleasure and honor for me when in 2025 DIPSI, Dr. Jitendra Singh has felicitated us for the best mass awareness campaign of Prega Talk in the country. So if I just talk about the introduction, this is just a history how gestational diabetes or pregnancy diabetes has been mentioned almost 100 years from now, 200 years from now, that 1824, where Benevitz has mentioned it as the first mention of pregnancy diabetes, and it was a topic of his thesis that pregnancy is a symptom of diabetes. That was a topic of his thesis. And before insulin, of course, the maternal mortality, especially in type 1 diabetes, was very high. The fetal mortality was almost 100%. And there was practically, once you are being detected to have type 1 diabetes, pregnancy was practically was not possible for them. And thereafter, we had wonderful progress as far as understanding of hyperglycemia and pregnancy is concerned. Now we say every fourth woman above is likely to have either GDM or pregestational diabetes. And this slide you must have seen ICMR data which was published in June 23, which says that almost 236 million, that is 23.6 crore people have dysglycemia, either pre-diabetes or diabetes. And the population of our people who are more than 18 years of age is around 96 crore. So more than 18 years of age, out of 96 crore, you have 23.7 crore people who are dysglycemic, that also includes all your women of childbearing age. And that's an indirect message to you that every fourth woman coming to your in your ANC clinic is likely to have gestational diabetes. If you remember the earlier definition of GDM, it says IGT in non-pregnant state is GDM in pregnancy. I repeat, IGT in non-pregnant state is GDM in pregnancy, and here you are every fourth adult above 18 years of age has either IGT or diabetes, so they will be having either pre-GDM or GDM. And it's a vicious cycle. We know that you have GDM, your next generation is likely to have obesity, non-communicable diseases in their adult life, and it turn out to be as women will another risk factor. So this vicious cycle has to be taken care. And everyone knows it is not the genetic predisposition, but also the epigenetic factor which actually have its impact on the growth of a child and the development of a child. And that is why we are supposed to detect mildest form of hyperglycemia has to be respected. Even if it is 125, you have to respect it. Because in non-diabetic pregnancy, the average blood sugar never crosses even 97 average blood sugars. It's not 105, though we recommend 105 mean you should try to achieve. But on an average, it doesn't cross 100, the mean blood glucose in a non-diabetic pregnancy. So anything above 120, we say, has to be respected and has to be treated. Then only possibly we will be able to take care of this epigenetic risk of hyperglycemia intrauterine environment to the forthcoming generations. Not only that, those who are known type 1 or type 2 diabetes, when they are planning their pregnancy, you have to take care of preconception counseling and care. Preconception care and counseling plays a utmost important role in all known type 1, type 2 diabetes who are aspiring for pregnancy, because the periconceptional HbA1c is more correlated with the neonatal outcome than the HbA1c which has been done at the time of diagnosis of pregnancy. So you have to focus on hyperglycemia much earlier before they get conceived. And it is the preconceptional, conceptional, sucking period, gestational period, even sperm maturation, everyone plays a role in the future of these babies. So 2 generations are going to be affected. The mother who has GDM is likely to pick up diabetes in future. Those offspring of diabetic mother who are born to these mothers are more likely to have obesity, type 2 diabetes, non-communicable diseases, higher risk of cardiovascular disease in their adult lives. So when you detect and treat the hyperglycemia in early stage, basically you are protecting 2 generations. This is a newer classification from FIGO. Now we have one umbrella term called as HIP or hyperglycemia in pregnancy, which is divided into 2. One is GDM, typically appearing in pregnancy, disappearing after delivery, usually comes after 24 weeks, commonly seen in after 20 weeks, but almost 30% of them, they may come before 20 weeks. So it's now being called as eGDM, early GDM. And those who are diabetes in pregnancy, already known or type 1, type 2, or diagnosed during pregnancy but have pre-existing diabetes, but the treatment will differ dramatically and drastically between the 2. DIP, we have to be more aggressive. most of them will require insulin. GDM, many of them will do well on metformin. Almost 70% will do well on only simply medical nutrition therapy. So you have GDM called as conventional GDM. Typically, I told you, over diabetes already known, but never diagnosed before getting pregnant is over GDM, over diabetes in pregnancy. EGDM, I told you, before 20 weeks of pregnancy. Mild GDM. You are giving glucose, 75 gram glucose, after 2 hours, not crossing 140. After it crosses 140 is GDM. But what about 120 to 140? Dr. Gupta, you came and you said the target is 120. 2 hours should not cross 120. Post breakfast, post lunch, post dinner, everything should be less than 120. Fasting should be less than 90, 95. But if after giving glucose, blood sugar comes as 131, what should I do? Your target is 120. Post GTT, and every woman in our country celebrates pregnancy, so every day she is going to have high calorie and sweetened beverages and everything. So everything there will be GTT if you keep it as negative. So anything above 120 has to be cautioned. So I'll come to that. So screening diagnosis, I'll not go too much into detail. There are multiple diagnostic criteria. IADPSG is one where you have to call women fasting, then give 75 gram glucose, take 1 and 2 and 3 hour test. If it is fasting in more than 92, 2 hour more than 180 or 1 hour more than 180 or 2 hour more than 153, one of the reading, we can call it as GDM. DIPSY does not need fasting. You can come fasting or non-fasting, just give 75 gram glucose, take 2 hour test, and if it is more than 140, we call it as GDM. This is Government of India guidelines from 2014, 2018. These are the SOPs of 2024. So almost 10 years, Government of India is sticking to DIPSY criteria, and they are now all the PSCs, you have these SOPs which are supposed to be followed. So again, 75 gram glucose, more than 200 is pre-gestational diabetes, and 140 to 199 is GDM. But there is another case called a gestational glucose intolerance when it is more than 120 but less than 140. So we have this GGI which has been proposed in 2006 by Professor Sheshaya. But then thereafter, after 10 years, after multiple years, or even during those days, few of the countries, Canadian government or the Australia, New Zealand, Netherlands, everyone has different names, but they also say above 120 has to be treated. Maybe many of them will do only on diet therapy. Only 5 to 10% may need pharmacotherapy, but even that will be at most important, whether you call it as mild GDM or borderline GDM. So we did some work on early detection of mild GDM in those who have past history of fetal losses. And we could see the 34% fetal losses has come to less than 4% from our study, which was presented in one of the international meeting. Glycemic target, I told you, fasting should be less than 90, 2 hours should be less than 120, and 1 hour can be less than 140, and mean should be less than 105. Now we have even CGM. So CGM, when we put the cutoff of CGM in pregnancy is different than non-pregnant state. Pregnancy, we say it should be 63 to 140 for TIR. Time in range should be 63 to 140 versus in non-pregnant state 80 to 180. So here your lower cutoff is 63, upper cutoff is 140. So that means nothing should go. Almost 90% of your reading should be below 140 and above 63 when it is GDM or when it is type 2 diabetes. But in type 1 diabetes, because of high risk of hypoglycemia, you can accept the TIR of 70% in this range. So what are the drugs? Of course, metformin, glibenclamide. Glibenclamide not being approved by Government of India at this moment of time, but globally, US people, they are using it. We use usually metformin, lifestyle modification, and insulin. Now, this is a diagram you must have seen earlier, that insulin doesn't cross the placenta. All other drugs, they are going to cross the placenta, and that is why insulin is supposed to be the safest one in pregnancy. So we'll discuss something about insulin therapy here. So insulin, we have one, this is insulin in LADA in type 1 diabetes pregnancy. So this is just simple case, a 20-year-old lady from Madhya Pradesh She has in July 2000, at the time of peak of the COVID pandemic, that time she has been diagnosed to have diabetes, moderate ketosis. That time she was having 2 weeks of, she had some pregnancy. At 28 weeks she was diagnosed to have ketosis, and she had, after 2 weeks of this, and she had IUD and she lost the baby those days. Then she get connected to our clinic in August 2020. And from there, she visited us, I feel, and that time she was admitted, she was put on multiple doses of basal bolus therapy as a case of type 1 diabetes. GAT65 was also positive, so it was a case of LADA later on, and she was put on basal bolus therapy. Preconception counseling was all done, and she was from, at that time her HbA1c was more than 10, now her HbA1c is 6.07, and she again came in 2021, almost 1 year after that. She came with pregnancy with 6.07 HbA1c. There are no all other tests were normal. What I wanted to show you is the insulin doses, and this is what is unique for Indian population, which we need to understand. The preconception dose in this case, being a LADA, was lower than the type 1 diabetes, and this case here you have around 0.7 unit per kg body weight before conception. When she got conceived, the dose goes up gradually. In around 36 weeks, went from 0.7 to 2.08. That means almost 3 times. At the time of after the delivery, on the day 10, it went to almost 50% of the preconception dose. And by the time she touched to day 30, it went up to 0.8 unit per kg body weight again. So this transition of insulin dose has to be learned, that how will you give insulin to a person coming to you with pregnancy, if it is type 1 diabetes, and how the insulin doses will be further increasing as the pregnancy advances, and what will happen at the time after the delivery, and till what date you will have to possibly wait to go for the preconception period doses. And this is a dose typically going up, typically going up, if you see, up to 36, 37 weeks, and suddenly it comes down to almost 10 units here, and then going again after 30 days. So intrapartum, she was put on the infusion, and that is the best way of treating intrapartum, trying to keep the intrapartum blood glucose to 70 to 120 to avoid neonatal hypoglycemia. So then we got encouraged from this, and we had a collaborative study of, this is a single-centric study of around 44 or 33 pregnancies. We again have found the preconception dose in type 1 diabetes pregnancy is 0.8 unit per kg body weight, and the mean at the time of delivery was almost 1.2, postnatal or 0.5, and the postnatal 30 days again has come back to 0.75. So this is the data of 33 type 1 diabetes pregnancy, how the insulin dose is increasing in pregnancy, and how it is behaving at the time of during conception, intrapartum, and post-delivery. Then we had a data on type 2 diabetes pregnancy, around 101 pregnancies, and we have again seen first trimester they are requiring around 0.5 unit per kg body weight. By third trimester it went up to around 0.8 unit per kg body weight, almost 2.5 times. What is more important to understand here from the central India is when you do post-breakfast, post-lunch, and post-dinner, the pre-dinner dose was found to be highest versus the pre-breakfast and the pre-lunch dose, contrary to our belief that the post-breakfast will be higher, or the pre-breakfast dose will be higher. So that was not seen, and we have then calculated the dietary habits of those people who were the part of it, and we have seen that they take lightest breakfast, they take little heavy lunch, and they take heaviest dinner. Now, very few of us monitor blood glucose after dinner. We are traditionally monitoring post-breakfast and post-lunch, but we forget to monitor post-dinner blood glucose. That is another message to you for Indian patients, that we have to do it. Now we have some data. This was the type 1 pre-GDM, type 2 pre-GDM. Now this data of gestational diabetes. Now when patient with GDM comes to you, 70% I presume that they will be on diet. 30% will need pharmacotherapy, either metformin or insulin. Now how do we understand that which person might need insulin therapy and which women might do well only on diet therapy alone. So this is a data with neonatal maternal outcome in women treated with diet versus insulin. And we had around 400 pregnancies in each arm, around total 800 pregnancies. And we have those who are put on diet alone from the day 1 till delivery, and another on insulin from the day 1 till delivery. And these are the highlights. Women receiving insulin had low risk of preterm low birth weight and macrosomia. Neonatal hypoglycemia was more common in insulin-treated group. 2-hour blood, this is another clinical clue to you. 2-hour glucose tolerance test value more than 162.5, so 163, and fasting or fasting more than 90 might need insulin therapy. And if you go through the CGM data in non-pregnant state, you again will see the fasting never crosses 70s. Fasting is at 71, 72. So fasting more than 90 or postprandial post-glucose more than 163 might need insulin therapy. So similarly, the individual with bad obstetric history, family history of diabetes, obesity, elevated fasting, postprandial as well as HbA1c, they are likely to require higher insulin doses versus the other group. And this again, which complicate neonatal hypoglycemia was more common in women who were treated with insulin. Other things were almost comparable. So again, if you see the birth weight is almost similar in both the groups. Sometimes we assume that when you go for intense treatment, intense control, you might exacerbate the chances of low birth weight, and there were some blames on these lines. But if you see insulin group versus the diet group, there is no increased risk of low birth weight, or there is rather low risk of macrosomia in the insulin treated group. Similarly, initial in the full-term insulin doses were again checked, and there was statistically analysis with propensity score mapping was done. And this is a law plot when they have done the propensity matching of this. This again juggling, which is statisticians, they do it. We don't do it, all this. But then we have divided this group, those who are on insulin therapy, into 4 different groups. So first, second and third group, if you see almost 95, 94 patients, all of them requiring almost 9 to 10 units at the time of diagnosis of pregnancy, till delivery almost 18, 90, 20 units if you see at the second line. But if you see the fourth quartile, your dose is 16 and 25. So what is the difference in these groups? So those women who have higher age, higher parity, bad obstetric history, positive family history, pre-pregnancy higher BMI, higher HbA1c fasting and postprandial are likely to go into this group of fourth quartile, and their requirement will be higher versus the other 3 groups. So this is another message to you that we have to, if you have these risk factors, you should be very much aggressive and for monitoring and getting the insulin treatment starting in them. Now, to summarize GGI, GDM, pre-GDM and type 2 diabetes and type 1 diabetes, this is the dose which you can just take a picture if you want, which might guide you in your clinical practice. How do you guide with patient with GGI requiring insulin? Of course, you are given the 2 weeks trial of metformin, everything is done. It is only on insulin therapy, 2 weeks trial of medical nutrition therapy, and then they are requiring insulin if you are giving insulin to them. Now, insulin in twin pregnancy. Now, we got this paper from US, which says type 1 diabetes have twin pregnancy have double the dose as that of the singleton pregnancy, which we never experienced it. So we have data of around 40 pregnancy from Nagpur and Pune centers from Dr. Sanjay Gupta, and we have found this around 40 pregnancies, 45 pregnancies. GDM women with twin or singleton gestation differed insignificantly in their treatment strategies and insulin doses. Insulin requirement need not be proportional to the number of fetuses. This is another message for our population. So we are not talking about the Caucasians. And then now there is an era of technology. So there's a concept trial where CGM system has been used in type 1 diabetes, and they have found that it is working there, and they have those, there's a better TIR, reduction in LGA, neonatal ICU admission was found to be reduced, severe neonatal hypoglycemia was again found to be reduced, and CGM use reduces hypertensive disorders and may be used for type 1 diabetes in pregnancy. That's what is recommendation is now coming up. The application of CGM and automated insulin delivery technology can be used in type 1 and type 2 diabetes and GDM. This is again another recent consensus in 2025. Now people have started asking me this question about GLP-1 analog. Now today is the first day of, we are all having GLP-1 analog, and there will be a lot of discussion on these points that it is off-patented today. So considering GLP-1 analog in pregnancy, in pregnancy it is absolute contraindication. But there are many women who are obese women who are infertility, who are into infertility, and they are for the fertility treatment and IVF. So these now IVF people have started using GLP analog pre-conception to reduce the weight, and then they switch over to for the IVF procedures. So what are the guidelines for this? First is GLP analog. There is no safety data available. We have only this 938 women who were accidentally become pregnant while on various different GLP-1 analogs, but there is no kind of red signal from any of these 938 pregnancy, but still we don't have dedicated data, so it is contraindicated. Even in breast milk, it is contraindicated. But those women who are using semaglutide, one has to withdraw semaglutide minimum 2 months prior to the procedure. And if you are using tirzepatide, you have to withdraw it 1 month prior to the procedure when you are using these drugs for weight reduction for the benefit of the fertility or for any fertility treatment. Postpartum care is very poor in gestational diabetes women, and the poor follow-up have the guidelines that we should be following these women very aggressively by doing GTT and their follow-up every year. So it's a rule of 6 days, 6 weeks and 6 months. These GDM women should, after delivery, should be subjected for OGTT, and then once in a year you should follow them. Similarly, preconception care and counseling also important for every one of them, which I told you. Last but not the least, to really achieve your goals of good earliest detection, intense treatment, and proper control during pregnancy, we have to have the education as a core in our system. I really appreciate in the previous session, one of the chairperson says, last but not the least is education. I feel that again holds very true when it comes to pregnancy diabetes. And education is the most powerful weapon before COVID, he has said, which you can use to change the world. This is Abdul Kalam who says, and that is why National GDM Day is the only day which is recognized in India for the awareness of GDM. If you go to any other country where they don't have National GDM Day, on 10th of March, which is the birthday of Professor Shishia. So we are doing this Prega talk almost last 3 years, and this Prega talk is being conducted in all 22 languages which are there in the constitution of our country, and regional languages. So we have here Kannada, where you can see LSM also, and many people who are there in the audience. We have done that, and then recently we have extended from Indian languages to even Sri Lanka. So the Sinhala language, Nepali we have done it. Next will be Bangladesh, and we have now started 3 cycles are being over. Now we started the 4th cycle was inaugurated. Rutul was there in that meeting, and many of you were the part of the DIPSI. On 8th of March, we have launched the 4th cycle of Prega Talk, which will be conducted from this month. And these are the appreciations from Nitin Gadkari ji about Prega Talk, and of course I told you the award from Dr. Jitendra Singh. Awareness, when we say we can use various platforms, this is one thing which I wanted to share with you. This All India Radio program and AIR and Vid Bharati program, which are doing it last 25 years, every 2nd and 4th Friday. And pregnancy diabetes awareness again can be brought through this, apart from general diabetes and things. But this is one program which is live phone-in program. So you're sitting in the station and people are directly asking question for half an hour. So they have become very popular, and this is for the first time in the country, someone started on health, forget about diabetes, on any topic of health, live phone-in program started only from Nagpur, and that too on pregnancy diabetes long back. And then now all these programs are there in the podcast. So we have now around 106 programs which are now there available in the podcast. So even if you have not heard, no one has heard all this All India program on the day when it was broadcasted, now you can certainly go through the podcast and do this. Recently, last year, We started this publication, every weekly publication on various topics on diabetes. And being this oration, I feel proud to say you, we already completed around 40 articles, 45 articles publishing every week. And practically everyone from this part of the country are the part of it. We also conduct, when it comes to pregnancy diabetes, apart from CCE, BDM, ACMDC and NDEP, we are doing CCGDM programs since the day of its inception. Here you can see Dr. V. Mohan, who is a part of it. Beside that, with Dr. Sharat Pense, unfortunately, we lost him last year. And then on my right, if you see, it is Nitin Gadkari's wife, because it was more of a gynecology meeting, as well as Devendra Fadnavis' mother-in-law. So both leaders from this part, Central India, were the part of this particular program when we conducted the convocation. So last but not the least is, we have to inculcate some newer habits in our population as a clinician. May it be a physician, maybe a family physician, maybe it be a gynecologist. A new concept of fitness for pregnancy should be brought into the practice now. Those who are known type 1 or type 2 diabetes, they should get 90% of the pregnancies are accidental pregnancies. But if you put this concept of fitness, anyone has operating their cataract, they go for the fitness. But those who are planning for pregnancy, they never go for preconception counseling and care. And then you will end up into a soup that what is going to happen to this baby when they come to you with 20 weeks of pregnancy or 24 weeks of pregnancy with HbA1c of 10. So I feel that the day has come. Now you should start giving fitness for pregnancy as a clinician. The final slide is the long-term outlook of the offspring of diabetic mother. If the glycemic control can be maximized to the extent that the fetus no longer recognizes that the mother has diabetes, then the treatment of mother during pregnancy may become the first step in the prevention of obesity and diabetes in the offspring of these mothers. So if you really focus, if you want to protect the future generations, if you want that 2047, 20 years from now, no new diabetes person should be there, should be born. Means I'm saying the next generation, no new diabetes should be detected after 20 years. You have to focus on pregnancy today. That is what is primordial prevention we should be working on. The focus on the fetus for the future. And this is what is the mantra from Professor Sheshayya. With this, I stop here. Cut the fruit and not the cake is another mission. We are doing this since long. So cut the fruit and not the cake for giving healthy messages to the society. With this, I stop here. Thank you very much for your patience.
Thank you, Sunil Gupta ji, for an excellent oration. He deserves a standing ovation for delivering this 30 years of journey in handling pregnancy. What a wonderful illustration, literature support, personal experience has been exposed by Sunil Gupta ji. In 30 minutes, we witnessed a fantastic journey, fantastic message, and final slide, fitness for pregnancy is a key message that should go to every clinician. Thank you so much, sir. And I congratulate Srinivas Murthy and Elite Academy for selecting most appropriate person for a prestigious oration. It is well done, sir. Thank you so much.
Thank you.
Can we have a big round of applause, please?
Thank you.
So from food for thought to food for the soul, we move on to the lunch and we'll all be back by 2 p.m. Request all of you to be here at 2 p.m.